this slide to you all. I can tell you what are your class help so that you can do well. Also, please, I want to tell you that there are 2 lectures. As you see here, you can see my PowerPoint. Everyone? Yes? Yes, there are 2 lectures, there are 2 CVs and 3 primers. Please do them in the same order. First, you finish your lectures. There would be only 1 CV tested. And yes, primers will always help you. We have addressed some concepts of primer. So just to let you know what we did so that I can just go back to where we left. So what we did with protein is, first of all, we did amino acid primer. In amino acid primer, we did address Henderson-Hasselbalch equation. In Henderson-Hasselbalch equation, we did do in detail 2 things: weak acid, weak base drug absorption and buffers, right? Then we did primer for proteins. For protein primer, we did primary, secondary, tertiary, and quaternary structure. We did identify the bonds that stabilize them. We did talk about the disease. For example, did we talk about Prine's disease versus Alzheimer's disease? Yes, that was an extension of the primer into the lecture. Then we talked about the lecture globular protein. Did we talk about globular protein here? Yes. And did we distinguish hemoglobin from myoglobin? Yes. Did we talk about them as heme protein? Yes, hemoglobin being one of them. Iron, remember, shouldn't be in the state of anyone? We talked about it. Iron should always be in a state of, to carry oxygen, should be in a state of Fe+2. So then did we talk about methemoglobin? Yes. Apart from methemoglobin, did we talk about normal hemoglobin compositions? Yes, we did all that. So all I'm saying is let's start where we left, but we addressed the amino acids, we addressed the amino acid classification due to side chain, we did the non-polar group. We also, so just a second, did I mix the Henderson-Hasselbalch equation with acid base? So just go back because remember Henderson-Hasselbalch equation has actually 3 applications: acid, weak base drug, buffer, and also amino acid charge. Though amino acid charge I have not discussed in detail, but we did address amino acid non-polar and polar classification. So that is why I was talking about Henderson-Hasselbalch equation. So to go back, what do we have in globular protein? First, we started with primer amino acid. We introduced the side chain classification. We introduced the predominant non-polar group. We also identified 2 different proteins. Can you see my laser pointer? We identified 2 different proteins, protein in a polar versus non-polar environment, for which you should know the side chain classification. We did primary, secondary, tertiary, quaternary structure, bonds that stabilize them, and we did talk about Alzheimer's versus Prine's disease. Then we came to globular protein. We distinguish myoglobin and hemoglobin, both are globular protein. We also talked about heme protein, if you remember. We talked about iron should be in Fe+2. Then we talk about what if iron is in Fe+3? It loses the capacity to carry oxygen. Then we talked about not just hemoglobin derivatives, which are oxy, deoxy, hemoglobin carrying carbon dioxide, and methemoglobin. We also talked about normal hemoglobin composition, major adult, minor adult, major adult, minor adult, or fetal. Fetal, so you should know composition of all the normal types of hemoglobin. Did we talk about taut and relaxed form? Yes, though I will do the review today, so I'm not going into detail. I'm just refreshing so that we can restart from where we left. Yes, we talked about taut and relaxed form. And when do you stabilize taut form? So right shift or left shift? When do you stabilize taut form? Right or left shift? Right shift. Right shift is favoring delivery of oxygen to peripheral tissue. We identified that. We identified Bohr effect And we talked about factors that shift the curve towards the right or the left. Did we talk about, just give me two factors that shift the curve towards the left? Do you have any two factors that shift the curve towards the left? Hypothermia is good. So whatever shift right, opposite is left. Can you add two more? I know that low pH, low PO2, high PCO2, and high temperature shift to the right. But can you give me, other than these, opposite of these, that shift the curve towards the left? Very good. Fetal hemoglobin and carbon monoxide poisoning. Then ask yourself a relevant why. For that, should you know the factors affecting the curve to the right? All of them we identified, remember? Low PO2, high PCO2, low pH, all doing the same thing. Favoring ionization and stabilizing, making salt bridges and stabilizing thought form. Similarly, you got to answer yourself why 2,3-BPG shift the curve towards the right. Because of the 2,3-BPG is negatively charged. What's the heme pocket? What's the pocket of heme charge? And what is it due to? So you got to ask yourself a relevant why too, not just memorizing. We are not testing you on first degree questions. Histidine. Histidine creates a positive pocket of heme. And what gets stuck in it, if it's high, negatively charged 2,3-BPG. When 2,3-BPG is stuck in the positive pocket of heme, what plucks out? What is moved out? What is thrown out? Oxygen. So high 2,3-BPG also favors which form? Taut or relaxed? Taut form. So you got to understand these concepts though separately. Concept that fetal hemoglobin has gamma chain, it's protective, separate. Then the concept that fetal hemoglobin cannot bind to 2,3-BPG. Why? Because fetal hemoglobin have what chains? What chains fetal hemoglobin have? Gamma chains. Gamma chains cannot bind to 2,3-BPG. Also, in fetal hemoglobin, instead of histidine, there is serine. So you also got to understand that the pocket of heme got to be positive for 2,3-BPG to bind. Anywhere the positive pocket of heme is dampened, 2,3-BPG cannot bind. When 2,3-BPG does not bind, where does the ODC shift? If 2,3-BPG cannot bind to heme, ODC will shift to. If 2,3-BPG cannot bind to heme, where will the ODC shift, right or left? Left. So you got to ask yourself factors that shift the curve towards the right or left, but why? That's second and third order, not just memorizing. Memorizing is the first step, but asking yourself a relevant why. Also, right shift means decrease affinity of hemoglobin for oxygen because you need more and more partial pressure to attain the same P50. What is P50? It's the partial pressure at which hemoglobin is 50% saturated. As you move right, it becomes more harder, more and more oxygen is required. So right shift is decreased affinity of hemoglobin for oxygen. Then we did hemoglobinopathies, structural, qualitative, as well as quantitative. In which one of them the qualitative disorders or hemoglobin, the change is hydrophobic. And don't forget, this change is in which chains? Alpha, beta, or gamma. When you say glutamic acid by valine, is it in alpha, beta, or gamma chains? Anyone? Beta chains, please be mindful because I'll talk about treatment of sickle cell hemoglobin. But where is the change hydrophobic? Sickle cell, because glutamic acid is replaced by valine. So see, you are connecting. If you didn't know that valine is in the non-polar classification, you would not understand that the change is hydrophobic. So sickle cell is qualitative, but with a hydrophobic change and not HPC. They are quantitative. We were talking about that when last we left. Always you have alpha and beta. Alpha is 16, beta 11, and related chains. Why? Because this is exactly how it happens. Embryonic, it switches off, then fetal, and then adult. You know the two adults, major and minor. What is minor composed of? Minor adult. Minor adult is composed of alpha 2, minor adult. My alpha 2, delta 2, usually that is the hemoglobin that increase in compensation. I will tell you why. So you got to understand what is the change, where is the change. For example, beta thalassemia. Are beta chains low? In beta thalassemia, are beta chains low? Yes, in beta thalassemia. So which hemoglobin will be low? Major adult or minor adult? Major adult. So you know composition, then you can connect clinically. That is why you should know composition. So in beta thalassemia, major adult is low, and actually HbA2 is used to screen beta thal. Also, because beta chain rise later in life, gamma chain can offer protection, not to alpha thal fetus. Alpha thal fetus cannot be protected by gamma chains if alpha chains are low. Does that make sense? Because alpha chains rise early in life. Then we talked about these two, this qualitative, sickle cell, and quantitative. Beta thalassemia is please more common than alpha. Beta thalassemia, though, also, please, this is very, very important. It's only the deoxysickle hemoglobin that aggregates, not the normal adult deoxyhemoglobin. It never aggregates. That is why that hydrophobic change gives this novel property. What is the novel property? That the deoxysickle hemoglobin aggregates, precipitate at the base of RBC, giving RBC a sickle shape that cannot cross the capillaries, it occludes the capillary, and they have a painful occlusive crisis. All that you need to do for a sickle cell patient, you can't treat the disorder unless you treat the defect, is you avoid deoxy sickle hemoglobin formation or precipitation. Does that make sense? So what do you avoid? Infection, infection, hypothermia, going to high altitude, anything that increases viscosity, and they are also given painkillers. Qualitative is beta thalassemia. We have talked about tetramers, but please see tetramers are more clinically relevant for alpha thalassemia because alpha thalassemia is due to deletion. They have markedly reduced alpha chains. So which tetramers are detectable in alpha thalassemia? Anyone? Which tetramers are detectable in alpha thalassemia? What kind of tetramers will accumulate? So you got to understand this concept too. One hemoglobin is low, the other rise. One thing is low, the other rise for compensation. So there are a lot of concepts. Don't mix them, know them differently. For example, heme pocket should be positive. For 2,3-BPG to plug in, know it separately. Then fetal hemoglobin, gamma chains offer protection, separate concept. But this is also one concept. When your major hemoglobins are not working, minor hemoglobin rise to compensate. So what was I asking anyways? Alpha thalassemia, which tetramers accumulate to compensate? There is no alpha. So it will be two types. Alpha is gone. Which tetramers will accumulate? Gamma 4 and just gamma 4? They are not gamma chains, please. They are gamma chain tetramers. Gamma 4 and beta 4. Beta 4 is known as HPH, gamma 4 is known as HP BARTs. They are clinically used more in alpha thalassemia than beta thalassemia, right? You know, glutamic acid is replaced by valine, but you don't stop there, right? So when valine is, as glutamic acid is replaced by valine with chains, beta chains, they aggregate hydrophobic sticky patches, precipitate at the base of RBC, acquiring RBC sickle shape. Please know that it's only the deoxysickle hemoglobin which has this novel property of aggregation. Otherwise, deoxy adult hemoglobin does not aggregate, right? So, so what do you do as a treatment for sickle cell? Avoid deoxysickle hemoglobin formation. That's the key. You can also give painkiller. but you also give hydroxyurea. Why? Because hydroxyurea in sickle cell increases HbF. What's the advantage for that? If you give hydroxyurea to sickle cell patient to increase HbF, what's the advantage? Why would you want to do that? Why would you want to increase HbF? Anyone? For sickle cell patients.
It would be less deoxy.
That is one concept. Usually people talk about that. That is one concept, that HbF cannot bind to 2,3-VPG, a less positive pocket, shift to the left. But think about compensation. In sickle cell, which chain, where is the mutation? Which chains have the mutation? Beta.
The
So how
alphas.
will HbF help?
It doesn't have a beta chain.
Yes, because it's alpha-2 gamma-2. And yes, number one, it won't sickle, and it will also compensate and help sickle cell patient to have some kind of normal hemoglobin and its function, right? Does that make sense? Because it has gamma chains. Do you have any question, Diego? I think your hand was up.
No, I was just trying to answer.
Oh, okay, great. We talked about alpha and beta. Remember, alpha is because of deletion, beta is because of splicing mutation. Because it's because of deletion, the tetramers, that's why I have given a double arrow, please. First of all, it's quantitative. Alpha means no alpha, beta means no beta or low beta. But they are more diagnostic because it's because of deletion. The tetramers rise to a much higher concentration to be clinically detected rather than beta thalassemia. That's why there's a double arrow for tetramers in alpha versus beta thalassemia. Also, composition is important. What do you mean by no HP and some HPA? Why is there a problem in beta thalassemia? When you say there is, these are variants of beta thalassemia. Beta, please, is more common than alpha. And why do they label them as plus? What do you mean by HPA? Is a problem with HPA in beta thalassemia? Is there a problem with HbA in beta thalassemia? What is HbA? Is there a problem with HbA? Because they are labeled, they add, how bad is the consequence based on their, yes, major adult, right? Because major adult is made up of alpha-2, beta-2. So if it's very low, it's not good. It's not good for the patient. So they are labeled on the basis of whether there is a detectable HbA or there is very low HbA. HbA is major adult. That is why you should know the composition. In beta thalassemia, what would be low? Not HbF and A2. What would be low? Major adult, right? Does that make sense? How composition helps in clinical classification. So alpha means no alpha, beta means no beta, but alpha is because of deletion. That is why tetramers are more used as clinical diagnosis in alpha versus beta. You know the tetramers. If alpha is not working, the tetramers would be alpha 4 or beta 4. If no alpha, what would be the tetramers?
Beta 4s.
Beta 4 and?
Fetal.
And gamma 4. So see there, please don't, that's why I wanted these answers. Fetal hemoglobin is not gamma 4. Fetal hemoglobin is alpha 2 gamma 2. So there are different concepts. When major adult hemoglobin is low, minor and fetal rises. This is one concept. This is hemoglobin, right? These tetramers are not hemoglobin. They are abnormal tetramers, non-functional. Dr. Henshaw has also given a beautiful slide that they precipitate at the base of RBC as inclusion bodies. So this is not fetal hemoglobin. They are abnormal, non-functional tetramer. They are of no use, but only used for diagnosis. Did I clear that? Right? So when you say there is no alpha, beta 4, and gamma 4 are abnormal tetramer chains. Normals are only 3 types. I would say 4. Major adult, alpha 2. Major adult, alpha 2. Beta 2. Minor adult, alpha 2. Delta 2. Fetal, alpha 2. Gamma 2. And then there is glycated. So hemoglobin is different from So please distinguish that. Normal hemoglobin composition, hemoglobin derivatives, and these abnormal tetramers, they are not the same. You see these tetramers? They precipitate at the base of the RBC as inclusion bodies, and they can be detected. In beta, you will see different from alpha, but please know alpha is more used clinically. Tetramers are more used clinically in alpha thalassemia, but beta thalassemia is more common clinically. Why I told you the reason alpha thalassemia is because of deletion. So tetramers accumulate more to a higher concentration and clinically detected. Don't forget Tisha, and don't forget the our sickle cell case here. Sickle cell case sickling. Sickling is because of hydrophobic sticky patches, aggregation, precipitation at the base of RBC. But please know that sickling causes the occlusive crisis. Why in Jasmine, sickle cell patient have occlusive crisis, but also know that mainstay of treatment in sickle cell is to avoid any precipitating factor. One more thing, please, students make a mistake that what are these factors? Factors are the predisposing factors, and outcome is shift of curve towards the right or delivery of oxygen towards the peripheral tissue, right? So one thing which we want to avoid in sickle cell patient is what? What do you want to avoid in sickle cell patient? That is what happened with Jasmine. All the factors that favor the tart form shift the curve towards the right, whether it's low pH, acidosis, high altitude, hypothermia, stress. Stress, I'm not sure we would talk about stress. Are you really, look, I think you people are all stressed with physio right now. So I would not say that. I would say when you say sickle cell patient, you infections, hypothermia, going to high altitude, anything that shifts the curve towards the right, anything that stabilizes tart form is avoided in sickle cell patient. But unfortunately, Jasmine could not do that. She consumed alcohol. There was dehydration, increased viscosity. Alcohol can also lead to which kind of metabolic acid-base disorder? Alcohol can also lead to which kind of lactic acidosis? Again, all that lactic acidosis, increased viscosity, infection, high temperature, hypothermia, going to high altitude, all of them will favor what form? Oxy sickle cell or deoxy sickle cell? Oxy or deoxy sickle cell? Any of these factors, deoxysickle, and deoxysickle aggregates and precipitates. So that is why Jasmine consumed that, and she had precipitation of attacks. Remember, all the time you have predisposing factors that you need to avoid in sickle cell patient. So you got to understand the sequence, the concept, not just memorize that you want to avoid deoxysickle hemoglobin. Any factors, for example, in this case, alcohol that increased viscosity due to dehydration, anything that favors deoxy, all these factors. Tell me, all these factors also shift the curve towards the, all these factors also shift the curve towards the right. So I'm not saying stress is not the cause of it, but in Jasmine, the cause was alcohol ingestion and dehydration and increased viscosity, which is the second one, right? And that is why, what was the anion gap here? Please, whenever you're going to give an anion gap, calculate it. What's the anion gap here? What's the anion gap in Jasmine? 21. Is it high? Normal is 8 to 16. High anion gap is seen in anyone? High anion gap is seen in which acid-base disorder? High anion gap is seen in which acid-base disorder? Whenever anion metabolic acidosis. See, you connect from globular protein, go back to your metabolic acidosis. It's because of gain of acid or loss of bicarb. Very good. So I like that answer. Anion gap is high in metabolic acidosis. But now tell me, anion gap is high in metabolic acidosis due to gain of acid or loss of bicarb. Anion gap is high in metabolic acidosis due to gain of acid or loss of gain of acid. Exactly. Very correct. So see, you go back and connect. This is how you get better grades. You don't just stop here with anion gap. Evaluate anion gap and its different causes. I'm just finishing this and I'm opening for question and answer. Give me 1 minute. We are almost over. So know that Jasmine is a case of sickle cell. Sickle cell, all we try to do is avoid deoxysickle hemoglobin. We avoid every factor that shifts the curve towards the right. Anion gap high showed that the Jasmine had metabolic acidosis. pH also showed that, right? And what is this hyperventilation? Where does hyperventilation come here in metabolic acidosis? Hyperventilation is what in metabolic acidosis? Is it the primary compensation? Exactly. And that is why she is tachypneic. The compensation for metabolic acidosis is hyperventilation. So we talked about Jasmine, we talked about Tisha. Connect Jasmine with Tisha. Also understand the sequence of how Jasmine is a sickle cell patient. And
Tisha?
you want to...
Stevie.
Okay.
Oh,
She said
Tisha.
connect Jasmine with Tisha. So Tisha is another like
Stevie, I think.
Lydia, your microphone is open.
Okay, don't forget Tisha. Tisha is not your next door neighbor. Tisha was mixed acid base, and Jasmine is sickle cell patient. All you want to avoid in sickle cell patient is deoxysickle hemoglobin formation or shift the curve towards the right. That's all for today. Please, I just wanted to finish the slides. If you have any questions, otherwise you can, we'll talk tomorrow. Great. Yes, what's your question?
My only question is for when it comes to anion gap and we're deciding if it's hyperchloremic or normal chloremic, is there such thing as hypochloremic or
No,
just normal or
just hyper or normal? Yeah,